Well, thank you for joining us today. My name is William Andrews. I'm professor and chairman of the Department of OBGYN at UAB. And the topic for discussion this morning is entitled Preterm Birth and Cervical Length. Who should you screen? What should you do? First of all, I have no conflict of interests to report. This is a confusing topic, and hopefully we will help you understand some of the issues related to the confusion that lead to some of the controversy on this topic. And the learning objectives are summed up in this slide. At the end of this lecture, you should understand the newest concepts related to use of progesterone and cerclage to reduce preterm birth among women with a short cervix. You should also understand the controversies related to the use of these modalities and understand the controversies related to clinical cervical length screening. As you all know, preterm birth occurs now, at least in the year 2011, in 11.7% of all pregnancies in the United States. And in many ways, it is the nemesis of obstetrics, accounting for approximately 70% of all perinatal mortality, particularly if you exclude congenital anomalies, and up to 50% of long-term neurodevelopmental delay. Historically, the etiology of preterm birth has been broken down in a simple fashion as shown on this slide. About 50% occur as a result of the spontaneous onset of labor, known as spontaneous preterm labor, or spontaneous preterm premature rupture of membranes, which accounts for 30%, and preterm birth that is indicated for a variety of maternal and or fetal indications, accounting for approximately 20%. Including spontaneous preterm labor and preterm rupture of membranes in the same group has been referred to historically as spontaneous preterm labor. As we'll see in a few minutes, that is probably an oversimplification of reality. The prevalence of preterm birth is depicted on this slide. 9.6% of births worldwide, or 12.9 million births, occur preterm. 92% of these, or 11.9 million, occur in Africa, Asia, Latin America, and the Caribbean. In the U.S., 9.4% in 1981 were preterm births, and that increased to 12.8% in 2006. This represented a 36% increase in only 25 years. There undoubtedly are many contributing factors. Often, an increase in the frequency of so-called indicated preterm births in singleton pregnancies has been looked to, as well as an increase in preterm births in multiples due to the increasing availability of assisted reproductive technology. Nevertheless, as I said, there are probably many more explanations for the increase. Fortunately, since the year 2006, the rate of preterm birth in the United States, which, as I said, peaked out at 12.8% in that year, has steadily but very slowly decreased, such that in the year 2011, the most recent year for which we have reliable data, the rate of preterm birth in the United States is 11.7%. We are happy to see the decline, but it's clear that we have a long way to go. In Alabama, the preterm birth rate is depicted on this slide. This rate peaked out in 2006 at 17.1%, and as you can see, just as the national rate has declined, the rate of preterm birth in Alabama has also declined, but is still much, much higher at 14.9% in the year 2011 than the national average. Both Alabama and the U.S. as a whole are far short of the 2020 goal for preterm birth in the United States, which is 9.6%. Spontaneous preterm birth has more recently been referred to as a syndrome. A syndrome is a single obstetrical disorder with a single phenotype, but caused by multiple pathogenic processes. In other words, Many women may look similar in that they are in preterm labor or that they have preterm premature rupture of membranes, but in fact, the etiology that caused these occurrences may be quite different among various women in the group. Another important factor to realize is that these women may have a long subclinical phase. That is, that there's something going on long before preterm labor or preterm rupture of membranes becomes clinically evident. This is actually a good thing because this allows us the possibility, if we could figure out how to identify these women, to implement preventive measures that might reduce their risk of preterm birth. And there have been millions of dollars spent over the last 20 years unsuccessfully trying to do exactly that. It's also important to realize that preterm birth may result from a complex gene-environment interaction. The environment is often very difficult for which to control. Let's talk a little bit about progesterone. It was isolated and characterized in 1934. The role in myometrial quiescence for progesterone was reported in 1954. You should also know for this discussion and others that the term progestins includes both natural progesterone and a variety of synthetic forms of progesterone. What we do know is that a decline in progesterone action is associated with parturition onset, and it may be associated with a shortening of the cervical length, and if this occurs, it may predispose to preterm birth. There are approximately 15 different hypotheses that have been proposed by which progesterone may reduce the risk of preterm birth. Probably some of them are correct, probably not all of them are correct, and the probable truth is that there are more than one modality by which progesterone works to prevent preterm birth, if in fact it does so. But it is commonly viewed that progesterone may have an anti-inflammatory effect, which may counteract the inflammatory process that is strongly associated with spontaneous preterm birth, particularly at earlier gestational ages. And also there may be a local tissue effect that counteracts a functional decline in progesterone action. Not necessarily the progesterone levels, but possibly progesterone action at the level of the cell. This results in a delay in parturition, and it may prevent further cervical shortening and preterm delivery. Many ascribe to a hypothesis that was put forward by Roberto Romero in 2007, and Dr. Romero stated that an untimely decline in the action of progesterone may predispose to one mechanism of disease in the, quote, preterm birth syndrome, unquote. Many of you are familiar with this study, now fairly famous, published in the New England Journal of Medicine by Paul Meese and other investigators, making up the steering committee for the Eunice Kennedy Shriver National Institute of Child Health and Human Development Maternal Fetal Medicine Units Network. It was published in the New England Journal in 2003. All women enrolled in the trial were at high risk to have a preterm birth by virtue of the fact that they had had a prior preterm birth. They were randomized into a trial in which they received 17-alpha hydroxyprogesterone caproate, abbreviated as 17P, versus placebo. The 17P or placebo was administered in weekly injections beginning between 16 to 20 weeks and continuing to 36 weeks or until preterm birth occurred. Here are the results of that trial. In the yellow bars are patients who received placebo. In the blue bars are patients who received weekly injections of 17P. As you can see from the graph, that preterm birth was statistically significantly lower in the 17P group compared to the preterm birth group for births occurring prior to 37 weeks, prior to 35 weeks, or prior to 32 weeks. In fact, there was approximately a 1/3 lower rate of preterm birth among women who received weekly injections of 17P compared to those who received placebo. This trial was very, very popular. In fact, it was prematurely stopped by the Data Safety and Monitoring Board, which was monitoring this particular study because of the exceptional increased rate of preterm birth observed in the placebo compared to the 17P group. A trial that many people may not be quite as familiar with was published at almost the same time as what has become known as the so-called MEIS trial. And that is a trial published by De Fonseca et al., which appeared in the American Journal of Obstetrics and Gynecology in 2003. This was a randomized trial of daily vaginal progesterone versus placebo. The trial was performed in South America, and admittedly, this manuscript is a little bit confusing to read. But as far as can be determined, either the placebo or the daily vaginal progesterone was initiated at approximately 25 weeks in the pregnancy. All of the women in this study were considered to be high risk, which was defined as having either one or more prior preterm births, having a cerclage in place, or having a uterine malformation. Now, obviously, these three conditions could represent remarkably different etiologies of preterm birth. Some have argued that this leads to confusion regarding the trial. Others argue that it may be more easily extrapolated because there are multiple potential etiologies leading to the preterm birth. Nevertheless, here were the rather impressive results. Those receiving placebo in the yellow bars compared to those receiving progesterone in the blue bars had a significantly different result. The rate of preterm birth less than 37 weeks was approximately half in the progesterone group compared to the placebo group, and there was a remarkably lower rate of preterm birth less than 34 weeks among those receiving progesterone compared to those receiving placebo. Although this trial was impressive, perhaps the largest and more clearly conducted trial was that published in the New England Journal by Paul Meese and the MFMU network, and it is that approach that caught on after 2003, and many of us have been offering women who have a preterm birth in their history weekly 17P progesterone injections to reduce their risk of having a recurrent preterm birth. Many of you may also recall that the MFMU network conducted a large study in the mid-1990s known as the Prematurity Prediction Study. There were many papers that were published out of the data derived from that study, but one of the most famous was published early on, and it evaluated the cervical length and compared that cervical length to the risk of preterm birth. And what was found by Jay Iams and colleagues from the MFMU network was that women who had a short cervix were much more likely to have a preterm birth if that short cervix was identified early in the pregnancy compared to women who did not have a short cervix. In fact, the shorter the cervix, the greater the risk of preterm birth. So this begs the question that if progesterone has a role in preventing preterm birth, if high risk was defined not by other factors such as a prior preterm birth, but was defined as having a short cervix, will progesterone work? Fonseca et al. Published another trial in 2007 in the New England Journal of Medicine, which was a randomized clinical trial of daily vaginal progesterone compared to placebo, initiated between 24 to 34 weeks of gestation, a fairly broad range, allowing some patients to have their treatment started relatively late in the course of pregnancy. 413 women were enrolled in this trial, and women were required to have a rather short cervical length of less than 15 millimeters, documented to be present between 20 and 25 weeks of gestation. Here are the results of that trial. Again, the women who received placebo are represented by the yellow bars, and those who received the daily vaginal progesterone are in the blue bars. And as you can see, there is a remarkably lower rate of preterm birth less than 34 weeks among women who received daily progesterone compared to those women who received placebo. They also had a neonatal composite outcome, including neonatal death, and found that there was, although not statistically significant, a lower rate of this neonatal composite among women receiving progesterone compared to those who received placebo. So increasing interest began to be focused on the possibility that daily vaginal progesterone given to women who have a short cervix might reduce the risk of preterm birth. Not too long ago, Roberto Romero and colleagues published in the American Journal of OBGYN a literature review of 2,611 publications. Only 5 of these 2,611 papers were eligible for inclusion in a meta-analysis. They include the Fonseca trial that I mentioned just a short time ago, which involved women who had a short cervix, the O'Brien trial, which included women who had a history of a prior spontaneous preterm birth, the Rhode trial, which included women with twins, the Hassan trial, which included women who had a short cervix, and we'll talk more about the Hassan trial in a few moments, and the Satingas trial that included women defined as high risk. Here are the results of that meta-analysis. As you can see, only 2 studies suggested that daily vaginal progesterone was beneficial in reducing the risk of preterm birth. The yellow dots represent the odds ratio, and the horizontal bars represent the 95% confidence interval. When that bar does not touch the number 1, it is considered to be statistically significant. So we have the Fonseca trial of 2007 that suggested a benefit, and the Hassan trial that I mentioned a moment ago, which suggested benefit. No benefit was observed in the other trials, but if you combine them all into a meta-analysis, the combined result was benefit for vaginal progesterone in reducing preterm birth. This is easy to look at, but one of the problems with meta-analyses is that you have to be a little more granular to understand what the analysis is really telling you. And one of the ways to do that is to look at the relative contribution to the overall size of the meta-analysis contributed by each of the included trials. As you can see, the Fonseca trial included 250 women, which represented 32% of all women in the meta-analysis. The O'Brien trial, the Rhode trial, and the Satingas trial only included a small percentage of women that were included in the overall meta-analysis. Interestingly, the Hassan trial, published in 2011, which had 458 women, was by far the largest trial and represented nearly 60% of the women included in this meta-analysis, and therefore was highly influential statistically in terms of the result. So let's look at the Hassan trial. This was a randomized clinical trial that included women who had a short cervical length considered to be between 10 and 20 millimeters observed at 19 to 23 weeks. They were randomized to receive daily vaginal progesterone gel compared to daily placebo up to 36 weeks and 6 days. The primary endpoint was preterm birth less than 33 weeks. Now let me take a moment to explain this because it is a little bit confusing if you choose to look at the trial itself and subsequent documents, which I will explain later, that have been released related to this trial. What they meant here was that the primary endpoint was less than 33 and completed weeks, 33 completed weeks. In other words, really this is 33 weeks and 6 days. So some would argue that this should say less than 34 weeks rather than less than 33 weeks, but it is a quirky issue and you should keep that in mind as we go through the slides. I've kept it this way because that's the way it appears in the documents that you might choose to pull and look at, and hopefully this will reduce your confusion. The so-called Hassan trial had combined funding both by industry and the NIH. The trial included 458 women, as I said before. This represented 235 women who received vaginal progesterone gel daily and 223 women who received placebo daily. Now, this is an important issue in the trial. Even though there were only 458 women included in the trial, 44 different centers in 10 different countries enrolled these 458 women in the study. So as you might imagine, there are some centers that might have enrolled only a very small number of women. Here are the results of the Hassan trial. This is the primary outcome. That is preterm birth less than 33 weeks, and if you'll recall, that's really less than 33 weeks, 6 days. As you can see, women who received daily placebo had a 16.1% rate of preterm birth compared to an 8.9% rate of women who received the daily progesterone gel. And this was statistically significant at the 0.02 level. Keep in mind what this slide looks like, because in just a moment I will refer back to it with a similar appearing slide. Secondary outcomes for the Hassan trial included preterm birth less than 37, less than 35, and less than 28 weeks. And as you can see, there was no significant difference for preterm birth less than 37, but there was for birth less than 35 and less than 28 weeks. This trial was submitted to the FDA as a part of an application by the sponsoring company requesting licensing of the use of daily vaginal progesterone gel for the specific purpose of preventing preterm birth. And the FDA reviewed the Hassan trial in depth. They concluded that the applicant's analysis adjusted for only pooled study site and risk strata, and that many potential confounders were not included in the regression analysis for the original primary outcome published in the trial in the American Journal of OBGYN. They also pointed out that there were very few events at some sites. In other words, as I said before, at some sites, only a very small number of women were actually enrolled in the trial. And as a result, at some sites, vaginal progesterone gel was strongly favored over placebo and resulted in a markedly, and in some cases remarkably, lower rate of preterm birth. Whereas at other sites, the placebo was strongly favored, indicating that placebo was much more effective than progesterone gel in reducing preterm birth. So they concluded that there was a strong treatment by site interaction. The FDA reanalysis included acquisition of biostatisticians from outside the FDA, and when the analysis was performed, including the confounders that the FDA felt had been inappropriately left out in the original analysis, we see that the rate of preterm birth less than 33 weeks is only 15.2% in the women who received placebo compared to 8.9% in the women who received progesterone. And now it is not statistically significant. Now, personally, I don't really quibble with this outcome. As you can see, this slide looks nearly identical to the slide that I showed you just a moment ago. The only difference is that the original primary outcome reported in the article had a p-value of 0.02, which is statistically significant, and here it is not statistically significant with a p-value of 0.056. What I believe this demonstrates is the remarkable fragility of statistical significance, where a small change that really does not result in an appreciable point difference in the rates of preterm birth in two different groups finds itself statistically significant one place where it is not in another. This is probably true of many trials and probably accounts for our use of an arbitrary set point for alpha, that is p being less than 0.05, to define statistical significance. What is more concerning to me related to the Hassan trial is what's depicted on this slide. The FDA divided the sites into two groups, those sites that were in the United States and those that were not in the United States. And as you can see, inside the United States, among women who received progesterone, which is in the blue bar, compared to placebo in the yellow, there's hardly any difference, and it is clearly not statistically significant. But yet, among the centers who were not in the United States, progesterone was not only significantly beneficial, it was beneficial almost beyond our wildest dreams, with a multifold decrease in preterm birth observed in the progesterone versus the placebo group. And this is what has led to controversy. In the FDA reanalysis, the FDA stated that to prevent one preterm birth less than 33 weeks in women who have a cervix that is short, between 10 and 20 millimeters, the number needed to screen to find women with that short cervix is 604. And of those women that you do find, after screening 604 women, you have to treat 14 more women to reduce one case or prevent one case of preterm birth. As always, the FDA had an expert panel consisting of experts who are not part of the FDA. In this case, the panel had 17 members. Only 4 voted in favor of licensing the product. 13, based on the results of the reanalysis of the trial, voted no. So in January of 2012, the FDA came out with this statement. That is, to support drug approval based on a single study, efficacy evidence must be highly statistically persuasive. And the fact that a relatively small change in including or excluding confounders changed the result of the trial from statistically significant to not statistically significant was bothersome to the FDA, and they suggested that another large trial would be necessary to confirm this original trial. So in the light of this confusion, who should you screen? Despite the controversy still surrounding the efficacy of daily vaginal progesterone to prevent preterm birth among women with no prior history of preterm birth and with a short cervix on transvaginal ultrasound, some experts have recommended universal transvaginal ultrasound screening. That is to say that every pregnant woman in the United States, if you follow universal screening, would receive a transvaginal ultrasound at the cost of probably billions of dollars. Is this indicated, and would it be effective? Well, 2 studies have been published that are so-called cost effectiveness trials, and both have favored universal screening, and this is level 3 evidence. What did the Society of Maternal Fetal Medicine decide to recommend in their clinical guidelines? That's listed on this slide. In women with no prior spontaneous preterm birth and with a short cervix less than or equal to 24 weeks, daily vaginal progesterone can be considered, but it does not state that it is mandatory or is necessarily something that might be thought of as a standard of care. They also said that there are no data regarding the effectiveness of universal transvaginal ultrasound screening for a short cervix followed by progesterone in an effort to reduce the risk of preterm birth. The NICHD MFMU network is now developing a future study that will be starting soon, which is a randomized clinical trial of so-called low-risk women, that is, women who have no risk factors for a preterm birth. And what they will compare in this trial is universal screening in one group compared to incidental screening with transvaginal ultrasound in the other group. What is incidental screening? That would be use of transabdominal ultrasound, which is normally employed in the mid-second trimester to perform an anatomy screen of the fetus. The cervix can be evaluated transabdominally, and if it is suggestive that the cervix might be short, then based on that, a reactive transvaginal ultrasound can be performed to determine if truly a short cervix is present or not. The outcome for this trial is effectiveness of vaginal progesterone in either one versus the other group in an effort to determine if universal screening is necessary or indicated. The issue I have with this trial is that it presupposes that there is efficacy for vaginal progesterone, and that has been shown. I am not unique in this regard, but I personally disagree. And as the FDA indicated, another large randomized clinical trial should be performed. Having said that, however, there are many of my colleagues who take the opposite point of view. What does ACOG say in their clinical guidelines? That's listed on this slide. If the pregnancy is a singleton and has had a prior spontaneous preterm birth, then the clinician should offer progesterone, usually that is weekly injections of 17p, starting at 16 to 24 weeks, regardless of whether the cervix is short or not. And that is based on what ACOG believes is level A evidence. Asymptomatic singleton women with a prior spontaneous preterm birth and a short cervix detected prior to 24 weeks gestation, and short cervix defined as less than 20 millimeters, in those patients, daily vaginal progesterone is a recommended option, and the ACOG suggests that there is level A evidence to support that. I have shown you that evidence, and while it is level A in terms of the fact that it is a randomized clinical trial, there are questions about the outcome in that trial. ACOG also says that progesterone does not decrease the risk of preterm birth in multiples. In fact, there is even a suggestion that it may increase the risk. So avoid use of progesterone in patients who have a multiple gestation. ACOG clinical guidelines go further to say that among women without a prior preterm birth, universal transvaginal ultrasound screening is not mandated, but may be considered, and offer level B evidence to support that. One of the telling issues in the next year or two will be whether third-party payers will see it the same way and be willing to cover the cost of universal transvaginal ultrasound screening unless there are solid data to support its use. If adopted, universal screening should follow one of the protocols for transvaginal measurement of cervical length from one of the clinical trials on this subject, and those are available on the ACOG website. The last question we'll review is, are vaginal progesterone and use of cervical cerclage additive as a measure to prevent preterm birth in women with a short cervical length? Many of you may recall the trial published in 2009 by John Owen and colleagues, which was a multi-center randomized trial of women who had had a prior preterm birth. There were 1,000 women screened in the trial for the presence of a short cervix defined as a cervix less than 25 millimeters. The women were then randomized, if they had a short cervix, to either being expectantly managed without cerclage or having a cerclage placed. The primary outcome was preterm birth less than 35 weeks, and although lower in the cerclage group, this was not statistically significant. However, there was a halving and statistically significant lowering of preterm birth in less than 24 weeks in the pre-viable group among those who received progesterone compared to placebo. And in this group, fetal and perinatal mortality was significantly reduced. In a subset of that trial, Vince Bergella evaluated the patients who received both progesterone, in this case 17p, or no progesterone, and who also received placement of a cerclage. Women in this trial were not required to accept or decline progesterone as a matter of their participation, but they were allowed electively to decide whether or not they would undergo the weekly injections. So the sample size for this secondary analysis is somewhat small, and unfortunately simply does not answer the question as whether progesterone plus cerclage are additive or not. As you can see, there is no statistical value among those who received both versus those who did not at any gestational age less than 35, less than 24, or in terms of neonatal morbidity. Subsequent to this secondary analysis, a meta-analysis appeared in the American Journal of OBGYN in early 2013 that included 4 studies of vaginal progesterone compared to placebo and 5 studies of cerclage compared to no cerclage. In both interventions, there was a reduction of preterm birth less than 32 weeks, and in the meta-analysis, both had similar efficacy. While this is true, it does nothing to answer the question as to whether using both vaginal progesterone daily and placement of a cerclage is additive in reducing the risk of preterm birth. So the ACOG clinical guidelines say that there is insufficient evidence to assess if progesterone and cerclage together are additive, and they state that cerclage may increase the risk of preterm birth in twins, as I have said, if they have a short cervical length, and suggest that you avoid those. So this is my last slide, and this sums up the ACOG current recommendation among women found to have a short cervical length. If they have a singleton pregnancy and they have no prior spontaneous preterm birth, then it is reasonable to offer vaginal progesterone if the cervical length is less than 20 millimeters, and that is determined at or before 24 weeks gestation. If they have a singleton pregnancy and they do also have a prior spontaneous preterm birth history, then it is reasonable to put them on progesterone, in this case probably 17P, beginning at 16 weeks gestation, and you can consider adding a cerclage if the cervical length is also less than 25 millimeters, determined before 24 weeks, and the prior preterm birth occurred prior to 34 weeks. If they have a multiple gestation, there is no proven intervention. Thank you very much.